We will review the congenital anomalies, trauma, and inflammation of the pharynx. The most important congenital anomalies of the pharynx is the cleft palate. What is the pathogenesis of cleft palate? It is failure of fusion of the different parts of the primitive palate with each other and with the nasal septum. Etiology is unknown, but may be due to genetic factors like sibling or relative parents, or due to medications as in the anticonvulsant drugs during pregnancy. We have 2 degrees, the partial cleft palate and the complete cleft palate. The cleft palate may be alone, may be cleft lip alone, or maybe cleft lip and palate. This cleft palate alone, this is cleft lip alone, and this is cleft lip and palate. The presentations, the child usually complained of regurgitation of food and fluid from the nose, may nasal tone, and Eustachian dysfunction. And the Eustachian dysfunction, usually the patient have recurrent attack of otitis media with fusion. About the repair usually at the age of 18 months, because this is the age of beginning of articulated speech. This is the complete lip and palate. This is the results after repair. Trauma of the pharynx is very common, and the most common is inhalation or ingestion of the coin of a child. This is plain X-ray and posterior view. This is the coin, and this is the coin, and it's usually impacted in the cricopharyngeal sphincter, and we remove it by using the hypopharyngoscope. Accidental other foreign bodies, many types like this foreign body impacted in the right tonsil, and many accidental injury of the soft palate for children. Now we will review inflammation of the pharynx. The pharynx may be inflammation of the pharynx is called pharyngitis. This may be acute non-specific, acute specific, chronic non-specific, or chronic specific. Acute non-specific pharyngitis may be bacterial or viral. The acute specific may be bacterial like diphtheria, vaccinta, angina, viral herpes simplex, herpes zoster, fungal moniliasis. Chronic non-specific. This chronic non-specific pharyngitis may be catarrhal, follicular, hypertrophic, or atrophic. The chronic specific may be syphilis, tuberculosis, or scleroma. Now, acute specific pharyngitis. The etiology may be viral, adenovirus or rhinovirus, bacterial, Haemolytic streptococcus, or Haemophilus influenza. The symptoms: fever, malaise, sore throat, dysphagia. The signs: generalized congestion of the pharynx. As we see here, there is congestion of the whole pharynx. Here, so this color and this color, this is congested pharynx, acute pharyngitis. The complication may be otitis media or laryngeal edema in children. The treatment is rest fluid and systemic antibiotics. Now, the most important subject is diphtheria. Diphtheria is acute membranous inflammation caused by Corynebacterium diphtheria. Acute membranous inflammation caused by Corynebacterium diphtheria. What about the epidemiology? Usually affect the pharynx, maybe the larynx, maybe the nose, and rarely the conjunctiva. usually children from 2 to 5 years, and this incidence decreased markedly by the vaccination program. The pathogenesis, the infection usually by droplet infection, incubation period from 2 to 5 days. Then pseudomembrane is formed over the tonsil. This membrane is composed of necrotic epithelium. The organism causes necrosis of the epithelium, fibrinous exudate, blood cells, pus cells, and the Corynebacterium diphtheria. The Corynebacterium diphtheria secrete powerful exotoxin which go to the circulation, causing the complications. The clinical picture is marked toxemia, pale face, enlarged tender cervical lymph nodes, sore throat, moderate temperature, not more than 38.3 degrees centigrade, rapid pulse out of proportion to temperature, very rapid pulse, and we can see the membrane on the tonsil. It may exceed or extend to soft palate, pillars, posterior pharyngeal wall, and the larynx. The membrane, when removed it or detached, reform very rapidly and leave bleeding surface. The membrane is green in color with strong fetor. This is very bad odor. There is some associated condition like cough, racing heart, and maybe difficulty of breathing. About the diagnosis, we have to use pharyngeal swab from the tonsil to discover the Corynebacterium diphtheria. Differential diagnosis: acute follicular tonsillitis, Vincent angina, mononucleosis, and infectious mononucleosis, and all this will be discussed later. Complications. The complications may be early in the first week or late in the second or third week. In the first week, maybe from the membrane by extension cause laryngeal obstruction, by inhalation called lung collapse. So the membrane may cause laryngeal obstruction or lung collapse. The exotoxin may cause toxic myocarditis or acute nephritis. The exotoxin may cause toxic myocarditis or acute nephritis. Now, what is the complication in the second or third week or the late complication? This only from the exotoxin, which cause peripheral neuritis and affect 3, 4, 6 cranial nerves. This will cause ophthalmoplegia and diplopia. Here, affect 9th, 10th, and 11th cranial nerves, and this will cause palatal paralysis, laryngeal paralysis, pharyngeal paralysis, chest muscle paralysis, and cardiac muscle paralysis. The palatal paralysis is the most early sign, and the patient will regurgitate food and fluid from the nose, and the uvula will push to the normal side. Laryngeal paralysis will have hoarseness, pharyngeal paralysis will have dysphagia, chest muscle paralysis and cardiac paralysis will cause respiratory failure, heart failure, and finally death. Treatment may be curative or prophylactic. Curative should be hospitalized and should be isolated. This antitoxic serum, this intravenous or intramuscular, 30,000 to 100,000 international unit according to age and to severity. That should be taken as early as possible, even on suspicion, because the toxins, when fixed to the tissue, the antitoxic will not remove the toxins. The penicillin is a drug of choice to kill the Corynebacterium bacteria and should be used for 10 days. Prophylactic, the DTB vaccine, which is for diphtheria, tetanus, and pertussis, and this should be used intramuscular in 3 doses at the age of 3, 4, and 5 months. And also, a patient or the child has another booster dose at the school age. Prophylactic also, you can give 3,000 to 10,000 international units to the contacts of the patient, like his mother. Vincent's angina. What is Vincent's angina? It is an acute ulcerative lesion involving one or rarely both tonsils. So it is acute ulcerative lesion, usually affect one tonsils and rarely both tonsils. It is ulcer covered by a membrane. Ulcer covered by a grayish membrane. The ulcer is irregular and bloody. The patient usually complaint of fever, malaise, and sore throat. The fever is higher than in the diphtheria, but the malaise is less too much than the diphtheria, and the patients usually diagnosed by a pharyngeal swab, which will give us the causative organism, which is Borrelia vincenti and fusiform bacilli. Borrelia vincenti is spirochetes, and fusiform bacilli is a gram-negative organism. This membrane may extend to the pillar, soft palate, and gums, but when detached, not easily reform again and not giving too much bleeding like the diphtheria. Also, there is some fetor, but not too much strong like in diphtheria. The treatment here is oral hygiene like mouse gargle, broad-spectrum antibiotics, and metronidazole. Metronidazole is given as combined treatment with antibiotic because metronidazole is very effective against anaerobes. Now, moniliasis or thrush is a fungus infection of the pharynx by Candida albicans. This fungus infection of the pharynx by Candida albicans. This is white patches of thin membrane, easily removed. We can remove it by the tongue depressor, no bleeding and no reformation. Only there is mild sore throat or some discomfort of the throat. Not everyone can be infected by moniliasis, only the patient with lowered immunity. This may be due to prolonged use of antibiotics or steroids, or have immune deficient states like AIDS or severe diabetes, or irradiated by radiotherapy for cancer or using chemotherapy. All this decrease the immunity and predispose to monilial infection. Treatment is oral hygiene like mouthwash to remove these patches, and then you can use nystatin suspension, and in severe cases we can use amphotericin. herpetic lesions of the pharynx. The most common herpetic lesion of the pharynx are herpes simplex and herpes zoster. What is the presentation? This is small vesicles. This is a small vesicle burst to form shallow painful ulcer. So vesicle burst to form shallow painful ulcer, and the ulcer surrounded by a red area. Vesicle ulcerate to form a shallow ulcer, and the ulcer surrounded by a red area. The incidence here is very common. Here is rare. Site here bilateral, unilateral, or anywhere, but here usually unilateral. In nerve distribution, here not follow any nerve distribution, but here usually follow a nerve distribution. Here this is a branch of the glossopharyngeal nerve. The pain here moderate, but here is very severe. The patient, any patients here, young, middle-aged, or old age, but here the special patient, which is debilitated patients with lowered immunity. The treatment is acyclovir and steroids. Now we have to review chronic non-specific pharyngitis. What? Chronic non-specific pharyngitis. This is due to recurrent attacks of acute pharyngitis. Why recurrent attacks of acute pharyngitis? This means there are predisposing factors. The most common here are sinusitis because of descending infection, because of nasal obstruction, gastroesophageal reflux, excessive tobacco, or any cause which lowered immunity. These are predisposing factors which cause recurrent attacks of pharyngitis. What is the clinical picture of the types? First, catarrh. As we see here, red congested mucosa with enlarged uvula. You see, red congested mucosa with enlarged uvula. Usually accompany or may accompany gastroesophageal reflux. May. Here, the hypertrophic or granular pharyngitis, can see here nodules of lymphoid tissue in the posterior pharyngeal wall, and this may accompany sinusitis. Here, the follicular type of chronic pharyngitis, we see here yellowish cysts in the posterior pharyngeal wall, and usually accompanied by acute follicular tonsillitis. Here is the atrophic chronic pharyngitis. Yes, usually accompany the atrophic rhinitis, and you see dry glazed mucosa with some viscid mucus, and you may see some crustaceans. The symptoms here, sore throat and hawking. This repeated cleaning of the pharynx. Usually the patients continuous hawking and mild sore throat is the main symptoms. The treatment, usually treatment of the predisposing cause, any reflux or sinusitis, and you have to increase immunity, and you have to reassure the patient because the patient usually worried about his health, and you have to reassure him. Now, chronic specific pharyngitis. These are syphilis, TB, and scleroma. Now, about syphilis, all of us know everything about syphilis, but our presentation here in the pharynx, in the primary, you can see the chancre. What is the chancre? Hard venous babule ulcerate to form a sore. Hard venous babule ulcerate to form a sore, usually on the tonsil or on the lip, and usually there is cervical lymphadenopathy. Secondary stage of syphilis, mucus patches, grayish mucus patches here on the tongue and on the soft palate. Here, generalized rash and generalized lymphadenopathy. Tertiary is the gamma. What is the gamma? It is a mass. Usually affects the bone here in the hard palate. The mass ulcerate, forming ulcer. What is the ulcer? The ulcer is painless, punched out edge, necrotic yellowish floor. The mass, when ulcerate, the ulcer affect the bone and cause perforation of the palate, causing oro-antral or oro-nasal fistula. Tuberculosis may be primary or secondary to pulmonary TB. You have here pharyngeal TB or pharyngolaryngeal TB. The presentation is a tubercle. The tubercle ulcerates to give an ulcer. The ulcer is painful, and the syphilis painless. Here undermined edge, and the syphilis punched out edge. Here pale granulation in the floor, and this in the syphilis necrotic yellowish floor. Now we have to just review the scleroma and the site of discussion, complete discussion of scleroma in the nose, but the scleroma may also affect the pharynx, but usually associated with rhinoscleroma. There is glazed mucosa with crustacean. Glazed mucosa with crustacean. Here the mass without ulceration never ulcerates. The scleroma never ulcerate, but here the TB and the syphilis there's ulceration. Here never, with crustacean and with adhesion. So especially here crustacean, no ulceration, but with adhesions, and the adhesions may be between the posterior pharyngeal wall and the palate. Thank you.